All right, I think we're all set. Well, thank you, Dr. Lewis, for taking the time to talk to me today about your work with assisted outpatient treatment. I wanted to introduce you to the MPS members and others who might be watching this video, but for those of you who don't know, Cynthia Lewis is the Director of Psychiatric Services for Johns Hopkins, helping to lead the way, doing the hard work in the emergency rooms for folks who come in acute states. But I wanted to first have you talk a little bit about AOT and specifically how it applies to your work and why it's been so important to you to advocate on behalf of the creation of an AOT program for Maryland.
Okay. Well, thank you, Dr. Means, for having me. Yes, I am director of our psychiatric emergency services. I've been in that capacity for about 5 years now, but most of my work was as a community psychiatrist for about 15 years. And during that time, I was in a community mental health clinic here at Hopkins, seeing a lot of patients with chronic mental illness. We had a lot of services available for patients. We had therapists, psychiatrists, nurses, social workers. We had case managers. When our patients did well for the most part, but there was a population that didn't do too well and need a little bit more support, so that we would then refer them to mobile treatment or ACT teams and even capitation services. And I think it wasn't until I started directing the emergency department that I began to realize that not only that small percentage of patients, that there was another percentage that were failing treatment. And while in the emergency department, I began to notice a population that was coming to the emergency department multiple times a week, multiple times a month, sometimes even multiple times a day. And I would notice that these patients were very ill. They weren't doing well. They weren't really dangerous per se, but they were really leading substandard lives and not getting the care that they deserved. I often noticed that I would admit these patients hoping that they would get on medication and get back into treatment, but I would find them back in my emergency department about a week later. So I started to get concerned about why is this population cycling like this? They were often homeless. They often were being brought in with the police against their will because of emergency petitions. And it was that curiosity that led me to start thinking about, okay, why is this patient population failing? What is it in Maryland that we don't have? Why aren't we doing better by them? And it led me on a road to pretty much kind of advocacy and advocating to figure out what we can do to help this population. And what I found is that I thought it was state hospitals that we needed to rethink, and that we certainly need more beds. We need more state hospital beds. But during my research, I found that we don't have assisted outpatient treatment. And AOT, it's AOT for sure, but it's really court ordered, mandated outpatient treatment. Here we can involuntarily commit patients for inpatient services if we consider the person to be a danger to themselves. But what we didn't have is a way to mandate people to outpatient treatment. And it's really a very small set of patients who do not do well. And I realized that Maryland was one of 3 states that did not have it. And that kind of sent me on my journey. Okay, how can I get this tool for my patients who are failing miserably and cycling in and out of hospitalizations, emergency departments, homelessness, incarceration. So that piqued my interest, and that's where I set out to see how can I do better by that patient population.
Yeah, that's great. Yeah, it's funny, I'm a community psychiatrist as well, and treating those with severe mental illness, I feel like you always have those 1 or 2 patients on your caseload that fit this criteria.
Yeah.
They are chronically ill, usually, delusional, but not dangerous, right?
Right.
And
Right.
admittedly, there might be a hospitalization for whatever reason, but beyond that, often living with chronic symptoms of mental illness, and you really struggle to figure out effective ways to treat them. So I appreciate the effort. MPS has done a lot of work, did a lot of work in the 2024 legislative session year to be a strong advocate for the creation of AOT, and I know you led the way with that. So it's great to see it come into fruition as we begin to roll out the AOT programs in 2025, 2026. As you know, there are opposing views to AOT. So I was hoping you could summarize those a little bit. Like, what are the concerns you've heard when people talk about why not to have AOT programs? And how do you think we should think about those concerns as we move forward with the creation of the programs?
That's a very good question. And I will say, even though we have AOT now, in 5 years it does sunset. So there's the potential that it can go away. And I'm sure that people who had opposition will probably be right back with that opposition. So it's really, that's a good question because there are legitimate concerns. There were several key things that stood out to me when I was on the advocacy trail and when we were at the legislative hearings, hearing the opposition. One is patients' autonomy. When you think about taking someone's rights away. People were concerned that patients should have the right to refuse treatment. Patients should have the right to self-determination. And I agree. There are involuntary commitment laws for a reason. There are even laws within AOT that have to be adhered to. And I think my concern in that regard was that I think it was a population of patients, which again is very small, that people were not appreciating just how ill they are. And that sadly, this patient, when we talk about lack of insight, there truly is a term called anosognosia, which is truly a severe lack of appreciation that you have an illness or a deficit and something that needs to be treated. And it's seen in stroke patients, it's seen in our patients with severe mental illness. So it is a population that really just does not appreciate that they're ill. And so their ability for self-determination and for autonomy, they're really kind of lacking capacity for that. So the autonomy and the self-determination was something that was crucial and key and something that we had to put in its proper context. Another concern was the concern that there's going to be a racial discriminatory aspect to it. I know the opposition would cite studies, I think in New York, where there was a disproportionate amount of African American patients or marginalized communities in their AOT program when you compare to the population in the state. But we had to look. There were studies that were done that the APA actually looked at and said, no, there's no disproportion, unfortunately, because of systemic racism and social determinants of health and things of that nature. We've got a disproportionate amount of African Americans and marginalized communities that are already in that population of patients needing repeat hospitalizations, having chronic mental illness, and not being treated. So we had to kind of dispel to make sure it's not the program that's targeting people in a disproportionate way. It's that this population is already at risk, and there might be higher numbers, but they're in need as well. Another thing, we talked about the patients with lived experience. They were at the opposition table, and what I found is that we really needed to respect their experience. There were patients who are now advocates advocating for the patients to refuse treatment, and they were often given their experience when they were hospitalized against their will for something that they felt they shouldn't have been. They described their experiences and felt it was traumatizing and that it turned them away from wanting to seek help. So they were kind of thinking that these patients, they were concerned about that these patients forcing them to do something against their will could turn them off from psychiatry, and that maybe the better approach is to talk them into it or go have coffee or something, which is absolutely a first approach. But what I had to keep saying was, these are patients I see every day in my emergency department. We do try to talk to them, try to encourage them to seek help, to work with the peers. But because of that significant lack of insight and anosognosia, it didn't work. So again, respecting that they've had lived experience, they had bad experiences with involuntary commitments, but we had to really help them understand that we're talking about outpatient treatment, not involuntary admissions. And again, that we're talking about a very, a severe patient population that is really ill, and not, I had to kind of mention that, the people at the opposition table were able to go home to their nice beds. Most of them were working, had jobs, and doing well. But my patients are living under bridges, estranged from their families who can no longer care for them, who are coming in, who are dying early deaths. I had several patients who had died during this process. So I really wanted to, we need to respect lived experience and make sure that we're not putting AOT on a patient who does not qualify. There is criteria that needs to be met. The other thing that I would say is that I felt that there's a lot of misinformation out there. I kind of likened it to the mask mandate. Whenever you hear mandate or you're it's involuntary. There tends to be concern at all costs that you don't want to make someone do something that they might not want to do. But again, we really had to just really reinforce that this is a very sick population, a population that is not taking care of themselves, and they really need someone to advocate for them. So to me, those were the three main ones. I will say one last thing. Maryland did have outpatient civil commitment, which was a pilot project. And it was really an answer to AOT when it came out, with the desire not to really force it on anyone. And I think OCC meant well, but the problem is, again, it was voluntary, and it did not capture this population that I was seeing in my emergency department. So that opposition was at the table as well. And their concern was that it was going to divert funds from their OCC program, but we had to really, we kind of had to help everyone to realize that this program was really not capturing the patients who would benefit from AOT. So those are just some of the opposition that we came across.
Yeah. I think that appreciating that the whole purpose of AOT is to avoid those higher level of care, traumatic situations surrounding involuntary inpatient commitments, as well as forensic involvement that unfortunately too often these folks end up having. And it is important to know too that the current AOT law in its existence has both voluntary and involuntary arm to it. So hopefully we'll capture both. If you could, I mentioned briefly that MPS was particularly active in helping to advocate for the passage of the AOT bill in 2024. Did a lot of legislation, and I know you were there along with others helping to lead that. If you could just kind of briefly just review the work that has been done, as well as the work that continues to happen regarding the creation of the AOT program.
Yeah, good. That's a good question. I will tell you, when I first thought about, okay, what can we do? I was encouraged to join the MPS's legislative committee. And I'd been a member for a long time, but never really active. And when I was talking to my mentors about how can I help to get this AOT for my patients, it said, you need to join the legislative committee. So I did join, I think in 2022, and it was interesting because there were AOT bills that were coming up for about 20 years. And MPS, they agreed with it, but they were concerned about some of the things that I mentioned. And a lot of times it was more of the crafting of the bill that was the concern, not really what the AOT program is meant to be. So luckily we started supporting it, but with amendments in 2022. And I remember there wasn't really psychiatrists kind of at the table in 2022. But once MPS, our legislative committee, got on board with it, we were doing our legislative days in Annapolis. We were talking about the bills that we were supporting. In 2023, when the bill came up again, we called on senators and legislators during our days. And this time we met as a subgroup. Some of us, I agreed to do written and oral testimony there. And we also had a letter from MPS supporting the bill with amendments. The bill got out of the House for the first time that year. And so when then 2024 came around, I remember we kind of rolled up our sleeves even more. We got more people at the table. There were 4 psychiatrists who provided written and oral testimony. We brought this bill up when we did our legislative days. We met with Secretary Herrera Scott, who was our Secretary of Health at the time. Governor Moore championed AOT on his platform that year. So, we were just all kind of working together. We provided written and oral testimony. Luckily, it got out of the Senate that year and the House, and then got passed. And now what we've been doing, given this needs to roll out successfully in 2025 and then 2026, where there's an advisory council where myself and a few others who testified, we meet monthly as kind of an advisory council, trying to make sure that there's a clinician, kind of advisory to the state who has to roll this out. And I know we recently met, with the state as well, that they recognize that the Maryland Psychiatric Society, we are the psychiatrists here in Maryland. It's going to be us, making sure that we get the word out to our colleagues that there's going to be a need to treat these patients. And there's going to be a need for people to probably sacrifice some time to, go to the hearings if needed and, take these patients under our belt. So it's an evolving process. I'm glad that MPS is on board. I think that was important. I don't think this bill would have passed if there would have been opposition from MPS. And I think I was glad to see that a lot of us who knew that this needed to happen, that we kind of rolled up our sleeves, kind of figured out where's the right balance, because this is truly something that was needed for our patients. So.
Well, thank you so much for all you do. Also, thank you for doing our first ever, President's Column video. So, I think this is great. I think it offers the membership the direct voice, the words right from the people who are doing the work, and I think this is great work. So again, thanks so much for all you do.
So much, Dr.
Thanks
Means.
for again doing this video, and we look forward to seeing you do more in MPS as we move forward.
Thank you so much.
All right, thank you.
Bye-bye.